You are listening to the
World Extreme Medicine.
The World Extreme Medicine
Podcast.
In this session, we're going to look at expedition medicine pharmacology with Daniel Grace. What we're going to do really in the session is do a deep dive into some of the critical medications and indeed essential medications that you may need on a variety of expeditions, actually. So we're going to explore some of the essential drugs, their uses, how to manage common medical conditions far from medical care. So we're also going to look at some of the pain management, infection control, and indeed emergency interventional drugs that you might need in remote and or austere environments. So to do this, we have Daniel Grace with us. Daniel is no stranger to the podcast. He's both a GP, an expedition doctor, and also a FEM doctor, and also World Extreme Medicine faculty, and has just recently returned from the Livingston Expedition 2024. Welcome, Daniel, to the podcast.
Hi, good to chat again. Nice to be back.
I wonder if we could just kick off. It is actually quite a disparate topic, but one that really kind of marinates through, as I'm sure you're aware, on a lot of World Extreme Medicine courses around, what is essential versus what is nice to have from a medication perspective in a med kit. And I guess you've got a lot of contemporary experience, having just come back from expedition yourself. Daniel, could I get you to speak to initially some of the sort of top of mind essential medications that you recommend packing in a kit for an extreme environment?
Yeah, it's a huge topic, isn't it? And as you say, one that we discuss a lot on the courses and things. I guess it's and this isn't me dodging the question at all, but it depends a lot, doesn't it, on the location, the distance to definitive care, the screening that you've hopefully done on your participants or your expedition team. But I guess the main priority is, and it's always balancing, the things you're most likely to need versus the things you hope you don't have to use, but you kind of need to manage emergencies. But then also working out that, there's always a budget normally, and there's also the weight. It depends if you're carrying it, someone else is, whether it's a donkey. We've just come back from a vehicle-based expedition, so we had the luxury of being able to take a lot more stuff. So it's working out that, and I suppose getting used to the idea that you're delivering that real rather than ideal care. But I suppose the way I look at it is like, you need some stuff for your big emergencies, because it doesn't look too great if you haven't got that. But taking into account what is your ceiling of care as well, because you can't take a whole ITU with you, even if you might want to. And then it's also thinking a bit about, there's certain things that are going to be really common. I'd like to ideally manage those, but actually, is there a way of maybe getting someone to see a local healthcare facility? If it depends a bit on where you are. But I think if you're going with your essentials, I think you need something to treat your big sick sepsis. So, and we'll talk about antibiotics a bit later. But I think having some IV ceftriaxone, so just so if you've got someone who's massively septic, you can do something. Fluids is always a difficult one because each liter of fluids is another kilogram. We won't get too distracted on that one, but I think adrenaline is also important, more to manage anaphylaxis rather than thinking about sort of cardiac arrest. You're not going to really be taking your ALS drugs, but you do need to be able to manage those common emergencies. So thinking about some benzos for seizures, whether that's rectal or not. There's a bit of a move towards using nasal midazolam now, particularly in mountain rescue. We started doing that, and being able to treat hypos. Again, thinking about trauma. So ideally having a trauma kit and some TXA. Analgesia, again, we can unpack that in a bit more detail, but I think having something like Penfox, something that's short acting, so you can manipulate a joint, relocate a shoulder, something like that. But then and the Penfox is good, obviously, because it's not a controlled drug, but you have the whole issue of, yes, you'd love to have some wonderful analgesia, but you might not be able to bring it into the country. And then you're thinking, things that are common, actually, probably the most common thing is gastroenteritis. So I'm sure everyone listening, anyone who's traveled has probably had gastroenteritis when traveling. Most of the time it's viral. So do we need anything? I guess this is where it comes to, ideally you'd have some loperamide, maybe some oral rehydration salts, but actually how much of that do you bring if you've got 30 people? So a lot of it is you've got your key stock that you want, and actually empower the participants to bring all of those kind of common stuff, get them to bring the stuff to sort out their bowels, their feet, their fungal skin infections, things like that. So yeah, it's a difficult one, but I think those would be my key kind of emergency things. You can take the whole kitchen sink though, and it all depends on, I guess, the type of expedition, the length as well, and then also, yeah, is there somewhere where you can resupply or get medications in country as well? Because that may form part of it.
No, absolutely. And to your point, actually, Daniel, there's so many variables, the type, the conditions, the terrain, the existing facilities, and as you said, the environment. Is it hot? Is it cold? Is it jungle? Is it mountainous? And yeah, and then to your point around, the comorbidities or indeed the disease profile or lack of disease profile of the participants you're taking away. There's so many variables which all do need to be taken into consideration. I guess my question on the back of that might be, for the different types of expeditions like jungle or indeed desert, you've just come back from a very sort of desert-like environment, although it is quite varied, but there's a lot of desert, it's extremely hot. I suppose, what are some of the front of mind medications that you would, for a hot environment like the one you've just come back from, oral rehydration salts and other things? What are some of the, like you say, commonly used and or consumed medications and or different types of drugs that you would reach into the bag for?
Yeah, so for Zambia, when it was kind of reaching the high 40s, mid 30s, anything sort of between that, really hot. I suppose, a lot of the priorities were having a plan in place to deal with heat-related illness. Obviously, a lot of that is not medication as such; it tends to be just cooling people down. But having the ability to give people oral rehydration. Obviously, you can make that as well using some clean water, salt and sugar and things. So that's a good thing to be able to improvise. Actually, the main thing in Zambia that I was conscious of was taking enough azithromycin for gastroenteritis if we did have like bacterial gastroenteritis, and also thinking about malaria. So we were going to all take antimalarials, but there's nothing worse than feeling like you've been eaten alive, bitten everywhere, having good amount of antihistamines and things like that. But yeah, it does vary so much. And then obviously, if you're thinking more about polar expeditions, then you're thinking, okay, my risk is completely different. People are going to maybe get too cold, and again, that's not necessarily medications. It's more having layers and bags, sleep bags, wrapping people, vapor bags and stuff. But frostbites, you might take more aspirin, aloe vera, things like that, and then altitude, obviously, then your medications you're gonna want to take your Diamox, your nifedipine, your dexamethasone. So yeah, it varies, and as you say, it's so environment specific. I think that's where doing a really good risk assessment, looking at key texts like the Oxford Handbook, or looking at the NAFNAC. So I always use NAFNAC Travel Health Pro. It's really good to just look up whatever country you're going to, and you're like, okay, we need to take antimalarials. There's a risk of dengue, or actually, there's another good site called ProMed Mail, which is it shows you all the outbreaks of infectious diseases. So the main one we had to think about, and it wouldn't have affected what I put in my med kit, was Mpox, which was obviously in the DRC, which borders Zambia. Zambia didn't have any cases when we went. They had their first case a few days ago, but having your ear to the ground and just constantly reassessing, I think, is really important, and getting an idea of what happens in those environments from your peers. Whether that's people on the WEM courses, like either faculty members, or if you're going with a company, there'll be a post-expedition report normally, and you can be like, okay, last year they had loads of problems with gastroenteritis, or they had loads of problems with infected ulcers, from tropical ulcers, something like that. And then you can be like, okay, so I need to take loads of this, loads of that, and maybe less of something else. I think that's really valuable as well.
So you mentioned about pain management and the versatility of something like Benthrox, methoxyflurine, and its utility in multiple different domains, really, because, like you said, it's quite cardiostable. There's it's easily ingested or indeed inhaled and taken, and it is a versatile pain medication. Could you speak to sort of the wider pain ladder, or indeed what you would have in your toolkit, or indeed what you carried in your toolkit in Zambia? What was the ceiling? What was the entry points?
Yeah, it's a tricky one. I think we're not very good as clinicians at managing pain overall. I think we often tend to under administer analgesia, I think. And it's I think Penthrox is very good, as you said. It's been used in Australia obviously for ages. It's kind of being used a lot more in the UK. The nice thing about it is it at least at the moment, it can be exported from the UK and brought into other countries in a relatively straightforward way. Obviously, opiates tend not to be able to be, and that's what tends to limit. If we're thinking about the pain ladder, you've got your simple paracetamol, which everyone tends to say, paracetamol's rubbish, but at least it does something. Particularly when you're thinking actually can't necessarily bring tramadol, codeine, any very weak opiates into whichever country. And then once you're thinking about morphine, stronger opiates, you kind of need an export license from the Home Office and things. So actually getting decent analgesia, I think, is really challenging when we're going overseas. We essentially took paracetamol, Penthrox. We had some ibuprofen, some non-steroidals. There's always that caution with NSAIDs, whether or not you're going somewhere where if you're going somewhere really hot, people are getting dehydrated, not drinking enough. You have to think about knocking off people's kidneys. Certainly in endurance events, if you're working on an event and you're the medic there, often it's been like banned for the whole event, even though athletes will still pop them like Smarties. But I think if you're safe and you're making people hydrate, you can potentially use that. PR diclofenac, is obviously really good in hospital for things like renal stones and things. It's a good analgesic, but then be thinking about the limitations of what you can bring. I think analgesia is really difficult. I think we probably underestimate the importance of non-medical treatment. So actually, and this sounds a bit waffly, but actually reassurance, telling people that things are going to be okay, splinting, so putting a limb back in its anatomical position, realigning, I think that can make a lot of difference. But analgesia is a tricky one, I think, with with that kind of whole importing issues. And a lot of the time, so I've worked with various companies, and I won't sort of say who they are, they're like, oh yeah, most of the time we just take this and it's absolutely fine. And you're like, it's fine until I'm the person on the front of the newspaper, potentially, in a prison, and you can joke about that, but that you just need to look on some of these news websites. You see people who've just gone on holiday and accidentally taken their cocodamol with them. So it's a really tricky one. I think I always tend to use a website called the International Narcotics Control Board, which tends to say, you can take this into this country. You need a letter that states X, Y, Z. Or you can write to the embassy and things. But it's a bit of a grey area, and it is a tricky one.
So looking at something that you've actually had to deal with quite a lot recently, Daniel, around cold chain and just the storage and indeed storage of drugs and medications on expedition. Could I get you to speak to some of your front of mind tips around storage of medications in these kind of quite disparate, quite varied temperatures, extreme hot, extreme cold?
Yeah, it's really tricky, isn't it? So I was actually looking into this a little bit before kind of coming onto the podcast, and it's a huge topic, and it's one that's not really researched or sort of written about by most of the drug companies who make these medications. They'll have like a sentence saying, this drug is stable between whatever temperature range, but they don't really say very much about how that's been tested, how it's been researched. And actually, if you sort of look into the literature, again, there's not a huge amount of information. There's a really good article on the UIAA website, actually, that goes into your common emergency medications and whether they are okay to use after exposure to extreme heat and extreme cold and the things like that, which maybe we can link in the description. But it's thinking about capsules, for example. If they get too hot, they're just going to kind of melt and merge into one. And then what happens to the medication inside? There seems to be mixed evidence for like the heat stability of various different medications. There's an interesting study done in Burkina Faso where they looked at common medications and they're sort of exposed to sort of 40 degrees or more for a year. And then they were looking at the bioavailability and whether that changed, whether it didn't. The general consensus was that most medications were okay. The ones to sort of think about a bit more, I think, are things like adrenaline. So adrenaline, once it's been exposed to sort of a high heat, it's stable for about a year. but not really much past that. Insulin's obviously the big one. Anything with sort of proteins in can become denatured, and you have to think about either extreme heat, extreme cold with that. So it's really interesting, but I think it's not something that is very like, so if you want to find out about the heat or the cold stability of a medication, it's not actually that easy to get an answer. But I think having a plan at least in place where you can say, okay, we're going somewhere really hot. If we're vehicle based, okay, we can store it inside the vehicle. It's got air conditioning, that's fine. Or you can get insulated packs to keep insulin pens cool and things. But then I suppose if we're thinking about cold things, obviously, if you've got any medications in vials, the vials will freeze, potentially crack, and then you're thinking about the integrity of whatever's in that. And a lot of medications will then degrade on freezing, and so you've got a whole other bunch of challenges there. So it's interesting. And then if you're going somewhere where it's too humid, you've got everything is just getting wet. I guess that's probably the easiest one to get around if you've got enough plastic bags and Tupperware and things like that. But obviously, you don't want all your medications dissolving either. And so lots of challenges, I think.
Yeah, no, indeed, absolutely. So just to pivot slightly and look at something you mentioned earlier, actually, around common things occur commonly, and gastrointestinal illness is absolutely prolific. And I fail to. We do this on WEM course, as you say. Who hasn't had a GI upset or traveler's diarrhea? And everyone keeps a hand down because everyone has this. So, but could I get you to speak to some front of mind thoughts? But I think one of this could be a podcast in of itself about how quick people are to use antibiotics for, like you said, maybe viral infections rather than bacterial ones. And could I get you to speak to the self-limiting nature of a lot of travelers' diarrhea, and indeed what your approach is and what you have in your med kit maybe?
Yeah, it's really interesting, isn't it? I think. And yeah, you're right. You could do a whole podcast on sort of antimicrobial stewardship, as it's a huge topic. It's like a global health threat, and there's obviously so many guidelines we have to adhere to when practicing medicine in hospitals or GP. And then we go out on an expedition, and we don't quite hand out antibiotics like Smarties, but the threshold is obviously quite different, isn't it? And I suppose if you look at most of the evidence, most travelers' diarrhea is viral. And it's a case of actually supportive management, isn't it? Getting on top of fluids, or rehydration salts, things like that. Loperamide seems to divide opinion. Some people sort of swear by it, other people sort of less so. I think there's some evidence if you take it alongside antibiotics, it kind of has a synergistic effect. Most people seem to say, actually, I'll just let it all out unless I'm sort of tent bound or going on a long journey. I think the main thing to sort of realize is that, don't jump straight to your antibiotics. I think it's usually if it's been going on for sort of 3, 4, 5 days, it's getting longer, you're getting high temperatures, sort of worsening abdo pain. Certainly if there's blood in the stools and things, then I think antibiotics are reasonable. But most of the time it's azithromycin now, mainly because ciprofloxacin used to be used a lot before, but then there's been kind of growing resistance to that. Also because it can cause problems with your tendons and tendon rupture. If you're on an expedition where you're doing a lot of hiking or something like that, you probably don't want to predispose yourself to that. But usually a short, sort of either a stat dose or a 3-day course of azithromycin tends to sort of sort things out. But it is really interesting, the whole, should we give antibiotics for all these different things that we do on expeditions? Because you've obviously got a lot less diagnostic capabilities. You're working in a stressful environment. People have paid money as well, so they don't want whatever medical condition is potentially emerging to end their trip. And you're like, well, I haven't got any evacuation, so maybe I just need to get on top of this because it might become something worse. But also, common things are common. Just because you're in the middle of whatever place, it's not that someone suddenly got pneumonia. They might just have a cold, and it's just like, how do you kind of balance that? And it is interesting. Probably a neglected topic, I think.
Yeah, no, indeed. Let's look at wound infection for a second, because you did mention wound infection, and I think, like, again, common things occur commonly. And could you speak to your multimodal approach, maybe through iodine impregnated gauze or indeed otherwise, but also maybe some of the medications for, like you said, it's starting to become more systemic rather than localized. Could I get you to speak to your approach from a medication and or equipment perspective to infection?
Yeah, I think wound infections are difficult, aren't they? Because they're everywhere. Whenever you go on an expedition, particularly in sort of jungles, places like that, and it's difficult. I think again, some of it is managing expectations, and because you don't want to be the person who's like, oh no, I'm not going to give you antibiotics, and then they suddenly get a really bad cellulitis, and then people are like, well, why didn't you give that? But I think the flip side is that there's limited evidence for like prophylactic antibiotics. I mean, obviously, if it's like an animal bite or something like that, it's a bit different. But for your standard wounds, I think a lot of it is as you say, making sure it's clean, which is really hard in remote locations potentially. But irrigating it, you can use the plastic bit of a cannula. You can create some high pressure jet cleaner, and then hopefully you've got enough dressing. So for me as a GP, dressings is obviously a topic I'm better at now, actually. I think when I was starting out, it was one of those, serious knowledge gaps. I was like, there's so many different dressings. What do they all do? But yeah, assuming you've got a good collection of dressings, a bit of knowledge, maybe some inodine, so your iodine dressings, or Gelinet, something that can kind of promote healing. And then just getting people to actually take good care of keeping it clean, and then obviously as the medic you need to review it. I think it's always that balance between, like we're saying, appropriate prescribing if you like, but also making sure that you are sort of managing infections. And I think it's safety net. You've got that benefit of that you're with that participant for the rest of the trip. You can keep looking at it. It's not like you've got that 10 minutes or slightly longer to be like, oh, I'm just going to give you some antibiotics because I don't know what's going to happen. So I think having just like that pragmatic approach, but yeah, you're probably going to be more likely to prescribe than not. So it's difficult.
Yeah, no, indeed, and like you said, it's nuanced and complex from a variety of reasons, but also the advantage, as you're saying, to an expedition is that there is longevity. It's almost this continual patient consultation
exactly.
through time, which is a good thing.
Yeah, and that helps you deal with that uncertainty as well. Like you don't entirely know what's going on, and that managing uncertainty is something that as humans we're really not comfortable with. But yeah, at least you can then get a bit of an idea of using time as like a diagnostic tool. It's something that gets drummed into you as a GP, but actually for expeditions as well, I think it's really useful because you can be like, I'm not entirely sure. I know your arm's not about to fall off, but let's see what happens and just make sure obviously it doesn't. Yeah.
So looking at, you mentioned before about adrenaline actually and managing severe allergic and/or anaphylactic reactions, because it is a spectrum. And on one side is the localized allergic reaction. The other side of the spectrum is the profound systemic anaphylactic reaction with all its manifestations. Could I get you to speak to, because like you said as well, medications are limited. There's a finitude and a finite nature to what you can carry on expedition. In World Extreme Medicine, we've definitely optimized the way we carry and how much we carry of epinephrine, adrenaline, and also interestingly how much is in an auto injector and how you can extract further from an auto injector. But could I get you to speak to your approach to allergies and then indeed anaphylaxis?
Yeah, that's a really difficult one, isn't it? And I guess it comes back to how mmany EpiPens is enough, or how many vials of adrenaline is enough. And I know there's various case reports of having to give a huge amount of adrenaline pre-hospitally. It's really difficult. I think hopefully if you've got people with known anaphylaxis and you've done a good screening process, get them to bring at least 2 EpiPens. And as you say, they usually deliver the 300 microgram dose rather than 500, and then you can get, I think it's usually 2 or 3 additional doses out with 11. And there's some really cool articles on the Wilderness Medical Journal that sort of tell you how to do it. I think most kits, certainly the ones I've had, all tend to have adrenaline vials purely because they're cheaper than getting EpiPens and things. But yeah, it's difficult, isn't it? Because you can have refractory anaphylaxis and you can take your hydrocortisone and things like that, but that's going to take time. I'm lucky in that, touch wood, the anaphylaxis I've managed has been in hospital. Haven't had to manage that on an expedition. It's one of those things it's a really scary thing to have to sort of think about. I know, and I haven't had to do this, but I know you can make a dirty bag of adrenaline, so you can get 1 milligram put into a litre of normal saline, and then that will dilute it enough. It's a very crude way of having a sort of an infusion. It's sort of definitely not ideal, but it's kind of an in extremis, better than nothing type approach. You probably know more than that than me, but like, yeah, I think it's one of those things where you have to say, well, actually, there's only a finite amount of care that we can do. And hopefully we are avoiding whatever the trigger is. I think that the difficulty will be is if you have someone who's never had an anaphylactic reaction, and then they're bitten, or they encounter some sort of trigger that they've never had before, and then you're like, okay, this is not great. But yeah, I don't think there's an easy way of sort of sorting that, because you need evacuation, don't you? You need that next level care, and hopefully you've got enough adrenaline to sort of manage in the interim. Yeah.
Then could I get you to speak to the importance of prophylactic medications, or indeed the evidence around prophylactic medications such as malaria, or indeed for altitude sickness? Could I get you to speak to your approach into prophylaxis?
Yeah, it's really interesting, and anti-malarials actually. So going back to our Zambia preparation. So yeah, again, go to NAFNAC, go to Travel Health Pro, see what the actual risks are, because obviously some places you can get away with bite prevention, long sleeves, insect repellent, things like that. Other places it's a bit more high risk, and you may take ACT, so anti-malarial treatment, with you in your med kit so that you can treat someone if they become symptomatic. Or like most places, certainly Zambia, you take your prophylactic antimalarials. But then you've also got that sort of discussion, like some people are like, well, I don't want to take it. And even within my small team, we were having those kind of discussions, or people who live in that country, and they're like, well, I don't need to take it. So, or people who once lived in a malaria endemic place, who've then gone to live somewhere else. And so you have a whole lot of health beliefs and potential issues around it anyway. In the end, actually, everyone did take antimalarial, so it was okay. But you have to have enough time to sort of think about that, but also to be aware that not all antimalarials are going to be suitable for everyone as well. Certainly, antimalarials can, if you're on anti-epileptic medications or things like that, they can alter drug metabolism in the seizure threshold, things like that. So certainly Lariam, and I talk about this a lot when I do a session on mental health, has been really badly implicated with causing worsening mental health in people who've not ever had any previous issues, cause psychosis, sort of suicidal ideation, things like that. So yeah, there's a lot of evidence, obviously, like the whole of medicine, isn't it? Risk versus benefit. But yeah, obviously preventing yourself from getting malaria is super important. I guess it's just doing it in a safe and sensible way, which people don't always think about when they're just ordering it from wherever they get it. Diamox is an interesting one as well. Obviously, again, you could do a whole podcast on altitude. I think the important thing about it is just to accept that, yes, it can help people acclimatize, of course, but it shouldn't be a crutch for like using it to do an inappropriate expedition, or to do an ascent profile that is completely outrageous, like a lot of them are. I think it shouldn't be used as that crutch to sort of justify doing something that's not safe, which I think, and I won't go too much into that, but I think that does happen a little bit. And particularly a lot of expedition companies ask GPs to prescribe it as well. And you're like, I personally, as a GP, rather than with my expedition hat, I wouldn't be happy prescribing something that might endanger someone also when they're in another country. So yeah, it's interesting. And there's definitely a role, but I think the safety aspect is sometimes underplayed, perhaps. That's my diplomatic answer.
Could I get you to speak to expiration dates on drugs, and your thoughts on how you'd approach that on an expedition, from rationing supplies when indeed it's limited?
Yeah, it's a tricky one, isn't it? I mean, hopefully you've checked the dates before you go, and it comes into your planning, I guess, of things. But yeah, it's difficult rationing as well, isn't it? Because it comes into planning, like how much of a certain medication is enough. And we had this where we were planning some of the kit for Zambia, it's like, how much TXA do you take? How much trauma kit do you take? Bearing in mind we're in 2 vehicles. The worst case scenario is that both vehicles are involved in, a horrendous RTC. But then you're taking, a whole helicopter worth of equipment, which obviously you can't do. And so we ended up saying, okay, statistically, it's probably going to be 1 vehicle, probably going to be the front 2 passengers. We'll take 2 people's worth of kit, because you have to draw a line somewhere. And it's the same for antibiotics. It's the same for other things. Date-wise, it's difficult, isn't it? Because some of these dates are probably arbitrary to an extent. I'm sure there's data on, what medications you can use maybe for slightly longer. I think in terms of rationing, that you have to treat in people's best interests with the evidence of what's happening at the time. It's really hard, isn't it? I think saying, oh, well, we won't give you this just in case something else really bad happens in the future is probably quite hard to justify, just because it might impact on someone else's future treatment. I'm not going to give you this, but then hindsight is also really useful, isn't it? And I guess that comes back to maybe being able to use time as a bit of a diagnostic tool, manage uncertainty a bit more. That you might be like, okay, well, we've got lots of people with gastroenteritis, so lots of people with possible skin infections, but they're not all awful. Maybe let's see what happens over the next few days, maybe. But it is difficult because, the supplies are limited. Maybe that's when having a bit of a contingency as to, actually, if we use up all our antibiotics, we've got somewhere that we know we can supply in country. We know the quality of the drugs is reasonable. Having some sort of plan like that, I think, is quite important. But yeah, it's a tricky one, I think.
Could I get you to speak to just some of your thoughts? You've already spoken to antibiotics, actually, and some of the preferential antibiotics. Could I get you to speak to some of the specific antibiotics and indeed antivirals you consider having on a remote or indeed high-risk expedition?
Yeah, again, this comes back to how much space, weight, that sort of thing. I think, like with a lot of these medications we've spoken about, if you can use something that is good at treating more than one thing, I think that's quite useful. Obviously, it can then be used for lots of things. I think, having your big sick sepsis, ceftriaxone, something like that you can be like, you're super unwell, you've got meningitis, whatever, take this. We'll give this to you and hopefully get rid of you. But also having a broad spectrum oral antibiotics, so something like Pharmacology, you can use that for chest, you can use that for bites. It covers anaerobes is pretty decent. Having something to cover GI, so usually azithromycin. Skin infections is pretty common, so having fluocloxacillin, maybe clarithromycin, because obviously you have to think about your penicillin allergies. Then you're sort of like, well, how many more antibiotics do I need? Because some people might get a urine infection. I mean, you could probably cover that with your Amoxiclav. I mean, a microbiology consultant listening to this would be like, no, but you could. But then you're a bit like, well, how many things do I take? I think I'd probably normally take something to cover urine, maybe. You might want to think about doxycycline if there's, so if you're going somewhere where there's a high risk of tick bites and Lyme disease and things like that. So that can be useful for that. But I think it also comes back to what we were saying before. Most infections are still probably going to be viral. But then, you do still need to have your little pharmacy with you to better treat those common things. So, again, I think it depends a bit on your cohorts. I think if you're taking loads of diabetics with you, for example, so they're going to be more likely to have poor wound healing and worsening outcomes with infections. You may take different antibiotics, maybe, or you might take more of a certain antibiotic. If you've got someone who's always getting urine infections and they disclose that, you say, okay, well, let's make sure we take more of that particular antibiotic. So I think a lot of it is going to be tailoring it to your people, hopefully. But as a kind of basic starter pack, probably go with those ones.
So as we're coming to land on the conversation, just a couple more questions. One would be one which is discussed on courses and frequently comes up, but is nevertheless quite tricky, actually, which is managing chronic comorbidities, such as diabetes and or asthma. And just if I could get your thoughts on looking at how we do that over the longevity of maybe a longer expedition where medication access is limited. And also absorption can be tricky if someone does have, tablet controlled diabetic medication, and they're struggling with absorption because of a diarrheal illness. Could I get you to speak to just your thoughts on managing some of these chronic pathologies over time?
Yeah, so I think as we become more sort of what's the word? I think we're taking more people with chronic conditions or older patients as well, because most of the people with disposable income who come on these trips tend to be older. They tend to have more capabilities, don't they? I think it's a balance between empowering these people to sort of self-manage versus also getting them to tell you when things are starting to go wrong and not suddenly, telling you when it's a bit late. I think, with long expeditions or even short ones, I think it's making sure they've got enough medication. Probably that they've got twice as much. So that sort of advice of taking some in your hand luggage, taking some in your hold luggage in case one of those was to go missing. I think the big one with diabetics, particularly as technology advances and people are using pumps and the Freestyle Libre where you can check your blood sugars touching your phone onto it. It's like, yeah, that's all very good. That's super cool. But what if the battery goes? What if the pump breaks? I think saying, okay, yeah, bring some traditional insulin, bring some needles, bring one or maybe two BM monitors so we can actually know what's happening. And I think if you're taking diabetics with you, then obviously make sure you've got appropriate glucose in your kit, as well as glucogel to better sort out hypos and things. It's a difficult one, I think. Obviously, if you're taking loads of asthmatics with you, you're probably going to be taking more Ventolin with you. You can take more steroids, prednisolone. But then it's also, I think, people with chronic conditions, it's a lot of it's about managing their expectations, isn't it? Some of it is like, actually, yes, if you get a DK, which hopefully you've kind of risk assessed beforehand, we're probably only going to be able to do X, Y, Z and try and get you out. But the evacuation time may not be the limiting factor. Are you happy with that? And you may have decided in advance that actually that whole context is too risky. I suppose similarly, people with asthma, hopefully your high risk asthmatics, you'd get their control optimized before they come. But you may say, look, you could have an asthma exacerbation. I don't have a nebulizer with me. Look, I'm not going to have oxygen with me. I can give you this, and that's the ceiling. And some of it is going to be just having those discussions and managing those expectations and saying, look, this is the reality. Obviously, I'm going to do my best, and hopefully these things won't happen. But at least understanding that can maybe help, because I think a lot of the time, there's often an expectation reality mismatch. So yeah. Apologies if you can hear a flute or some weird noises in the background.
It's all good. No, it's all good. It's all good. Listen, I absolutely agree with you on that. And it is about having honest conversations and realigning expectations actually ahead of time to what's reasonable, appropriate, and achievable from managing chronic pathology. Looking at, so just as we come into land, Daniel, I guess I would like to look at some take-home messages, but just before we do, could I just get you to speak to administrating medications in situations where there is a certain level of reduced consciousness or indeed unconsciousness? Could I get you to speak to, because fundamentally it's difficult when, if it is diabetes and it's unplanned exercise, or not just unplanned, there's a misappropriation of how much exercise it has been involved. They maybe haven't taken enough food. Could I get you to speak to your approach to how you manage either the patient themselves, or indeed if you're not even with the patient, how you vicariously plan for managing medication administration through the team, maybe from a reach back perspective, what your approach to that is?
That's really interesting, isn't it? Yeah, I guess that's all, that whole kind of adage of if a patient is unable to consent, you obviously have to sort of treat them in their best interest in terms of what you think is most likely to be going on. And I guess obviously for someone with a hypo, hopefully that glucogel, hopefully that's a fairly simple fix. But at the same time, I guess it comes back to being like, if someone is unconscious, actually, what is our ceiling of intervention? What do we actually have here that's going to help? And I guess we could talk for ages about that. And I suppose having your alternate routes, thinking about how you can administer things. The reach back thing is really interesting, actually. I haven't had to do too much of that, but it is interesting when you have people who maybe are either junior in terms of being a doctor and they can prescribe, or you may have someone who can't prescribe and you're having to do things through PGDs. I guess a lot of that all comes back down to your pre-expedition planning, and hopefully you've got an SOP in place for, like, actually this is hypoglycemia, you've checked their sugar, it is whatever, it's 2, so you now follow the next step and you do this. And I guess you need to have those sort of things in place and things. But yeah, it is difficult. I think if you've hit that stage, something's gone a bit wrong earlier on in the planning exercise. But that doesn't mean it doesn't happen, of course. But yeah, I think it's really difficult.
Listen, thank you for the past hour, Daniel. It's been fantastic just to get your thoughts, actually. And you're right, it's massively disparate. There's so many different variables that you need to consider when you're looking at medications for an expedition. Could I just get you to speak to some take-home messages just for listeners, just so that they could almost call forward?
Yeah, of course. So I think the main points are probably planning and risk assessment is always important. I know it sounds really boring, but yeah, if you've done a good planning strategy, and that includes planning what to take in your med kit, and hopefully you don't have to use any of that if you plan really well. I think that makes a huge difference. I think also getting your head around the fact that you can't deliver perfect care. You can't take every single medication for every eventuality with you. And you have to make your peace with that. And I think that makes, once you accept and you share that sort of responsibility or discussion with the participants, and everyone's kind of on that playing field and you've managed expectations, I think that helps a lot. But I think that last point we were discussing, having some sort of reach back, some sort of top cover is so important and so useful, even for people who've done loads of expeditions and are really experienced. Like, I'd always want to have some top cover, even if you think you've got an idea of what's going on. Sometimes you just want to share that bandwidth and have that discussion. So yeah, I think those would be my take-home points.
Listen, thank you so much. Really appreciate your time, your thoughts, your insights, and indeed your perspectives on just indeed your last expedition. That's super relevant that you've been in that environment in the last few weeks. So mapping that contemporary experience through to this podcast has been super helpful. So thank you, Daniel.
Thank you. Always good to chat.
Thanks for listening to the episode. Please feel free to rate, review, and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website, where you can find more engaging content on extreme medicine webinars and indeed the collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical, and performance medicine. Thanks again.